Hey everyone, Dr. Z, welcome to the ZDoggMD show. Today, I have a special guest. Look, I moved back to the Bay Area so I could talk to smart people at places like UCSF and Stanford and in the Bay Area. And I was all excited, and then COVID hit. And it was Zoom, 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 and I hate Zoom. So today I have someone I've been wanting to talk to since this pandemic started. Dr. Bhattacharya is a Stanford professor of medicine, and he has training and specialty in economics. Actually, tell me, Jay, who are you, man?
Well, okay, so
not in a metaphysical sense.
Exactly. Right? So I am a professor of medicine, as you said, at Stanford University. I've been at Stanford on the faculty for about 20 years. I have an MD and a PhD in economics, and I study health policy and health economics. I've been working on infectious disease economics and epidemiology for 20 some years now.
So the reason I wanted to have you on the show was what you just said. You have the MD, Stanford trained, and PhD in economics, which means you can see in a way that many frontline healthcare people, including public health people, aren't able to see the bigger picture. Now, you came to prominence during the pandemic as one of the co-authors of the Stanford Seroprevalence study, which raised all kinds of interesting... I mean, tell me about that experience, because I was talking about your piece early on, saying, hey, if this is true, the actual infection fatality rate of this disease is actually much lower than we thought. It's still higher than flu, but it's not, as high as they've been saying in China. I mean, what was that experience like?
That was incredible. I mean, just an amazing, in some ways dispiriting, but also exciting experience. So let me can I go back just a little bit?
Absolutely.
So what got me into it was I had done some work during the H1N1 flu epidemic in 2009.
I remember that one.
It was a big deal at the time, right? But luckily, it didn't turn out to be as bad as COVID. But it was especially at the beginning, people were really, really panicked over the high fatality rates, the case fatality rates that were coming up out of all around the world.
I remember I was a practicing hospitalist at Stanford, and everybody was like, we're all going to die. It was a kind of a catastrophization.
Yeah. No, yeah. It's actually, and in the early days, there was good reason. There were these case fatality rates that looked like, Ebola. I mean, it looked terrible. In the months that followed, what happened was people did seroprevalence studies and found that there were many times more cases of infections than there had been cases in H1N1, and the infection fatality rate, which turned out to be about 100 times less than the initial case fatality rates in the H1N1 case.
So let me reiterate that for people who don't understand some of that terminology. So case fatality rate is when someone is actually tested for a disease, presents to care, and is diagnosed with the disease, and then how many people die out of that group.
Correct.
Infection fatality rate is, well, of all the infections that exist, including ones that we weren't able to openly diagnose, what's the rate of fatality in that group? And it was 100x different in H1N1.
In H1N1, that's right.
And so this got you interested then in when COVID came around, I imagine.
It looked like a repeat to me, right? So it looked like the people were finding enormously high case fatality rates. I think like World Health Organization said 3.4%. There was a piece published in JAMA in I think February that said, Journal of American Medical Association, that said 2.2%. And these are terrible numbers.
Horrifying numbers.
Yeah.
These are the kind of numbers that would cause you to lock down the entire planet instantly, because you're going to lose that percentage of your population if everybody gets infected.
Millions and millions of people dead.
Right.
If that number is in the United States alone.
Right.
If the numbers are right. So, but that was what happened in H1N1. I thought, okay, well, do we really know how many people actually have it? And at the same time, we're worried about how much testing resources we had. Remember, there was a shortage of tests. So we're holding on to the test to look at people who actually have serious disease, which is what you ought to do from a clinical perspective. But then from an epidemiological perspective, can you extrapolate that to say, okay, the population at large is 3% of us are all going to die if we get it. And we don't know the answer to that. So that's what led to the Stanford Seroprevalence study.
Yeah.
And the other seroprevalence studies I've worked on. So it was this hypothesis, like how many people actually have it, how deadly actually is it?
And so how did you do this study? Because there was a ton of controversy around the methods and the actual sensitivity, specificity of the assay that you use and all that.
Yeah, so that was a lot of confusion around that, right? So if we wanted to do a study that could be done very, very quickly, put in the field very, very quickly. At the time of the study, the FDA had approved for use they're called lateral flow assay tests. They look like pregnancy tests, like little pregnancy kits, right? So, and the one we used had pretty good error properties. Every medical test has errors. I mean, there's just not but there's, and you can't avoid that. That's just the nature of, we don't have a tricorder that can automatically tell me exactly what's wrong with you, right? We need to look at the numbers and interpret them. At the time, the FDA had put together had approved for use these little lateral flow assay tests, including the one we used for sale, but they hadn't approved them for general use in the population. Right? We could use them for research purposes, but not for clinical purposes. So we used one of those. The reason was very simple. There were two kinds of tests to do antibody testing. There's these ELISA tests, which are pretty accurate, and then these little lateral flow assays. For the ELISAs, you have to draw venous blood. It's really hard in the middle of a pandemic to go out and find, can I draw venous blood from you, a big vial of it, or I can just do a little finger stick. The nice thing about epidemiologic work is you can correct for the errors, which is what we did. Now, actually, I've run 3 seroprevalence studies. One with in Santa Clara County, one in LA County, and one with Major League Baseball.
Oh. Did you get to meet a lot of baseball players?
I got to meet a lot of no baseball players, but it was surreal. I got to be in a meeting with all the owners. It was just it was fantastic.
That's nuts.
I had to contain myself when I met the Yankees owner, but that's another thing. Yeah, so I ran 3 different studies. And the interesting thing about the studies was we used very different methods to try to disseminate them. So the Santa Clara study was the first one. It was a big study, 2,000 some people in the Bay Area. Actually, in Santa Clara County.
Right.
We wrote the study very quickly, and we released it through an open science process,
like a preprint.
A preprint, right? Exactly. So now the traditional path involves sending it to a journal. The journal then sends it to 3 anonymous reviewers. No one will hear about it except me, and that's how I spend my life dealing with this. 3 anonymous reviewers, all of whom always hate me. So
you're not used to the whole planet hating you at once.
Yeah,
right?
No, that was interesting. So we sent it to, and I got 10,000 peer reviews in one day.
Oh my gosh!
And it was, you know what? Actually, it was kind of interesting, exciting. I learned a lot.
Right.
So we'd made what I would characterize as a relatively minor error in standard error calculation, which we corrected within a week.
Right.
And the number that we got was absolutely stunning. Yeah. What we found was that the disease was 50 times more prevalent than people thought based on just the case numbers. So people thought in Santa Clara County there were 1,000 cases as of April 3rd, I think it was.
Right.
But in fact, there were, based on the study, you could tell 50,000 people had some antibody evidence of it at the same time.
Right. Which would correspond to an infection fatality rate at that time of what?
About 2 in 1,000.
2 in 1,000.
So that means not out of 1,000 people who got the infection, 998 survived.
So 0.2%.
0.2%
fatality. So double what we think the mortality is for flu.
Yeah, although I'm not 100% sure I know what the flu mortality. I know what the evidence is. It's unclear in the flu. No one's done the same kind of infection fatality rate numbers that they've done for COVID. They've done with the flu.
So in many ways, we're comparing apples to oranges when we're comparing flu.
Yeah. So let's come back to that flu comparison because it is interesting and important. But I think the key thing is, how much would you change your life for a 2 in 1,000 risk? And there's a couple other things we learned. So one is that if you're older, it's much higher. It's probably much worse than the flu, actually.
Yeah,
if you're older.
Order of magnitude.
Yeah, like 1,000. So if you're over 70 versus if let's say you're under 15 or under 10.
Yeah,
it's on the order of 1,000 to 1 difference in mortality probability. Right. So the flu is much more deadly if you're older. If you're over 70, let's say 65 or 70.
Right.
And if you're under
the flu or COVID you were talking about?
I'm sorry, COVID. I apologize. Yeah, it's COVID is much more deadly if you're over 65 or 70, and if you're under say 40, the flu is worse. That's what the seroprevalence study.
And that was the sense that I was getting early on too. And your seroprevalence study was supporting that. And you said something which we're going to get back to. I think that's the theme of this. How much would you change your life for a 2 in 1,000 chance? Right.
Yeah. And I think that age difference is important. The absolute number is also important because let's get back to that theme.
Yeah, absolute versus relative risk. Yeah.
So the interesting thing about that, so we released the LA County study. It was immediately accepted in JAMA and published.
Instantly.
It's the same number, peer reviewed. Yeah. I mean, I've never had such an easy time with review. I mean, it was very strange. So, whereas the Santa Clara study, it exploded Twitter. I'm not on Twitter myself.
Thank God for you.
Yeah, it was. Yeah, actually, probably good for my sanity.
It really is.
But and everyone on Earth was paying attention to it all at once. One study, right?
Right. Preprint.
And everyone was convinced that was absolutely wrong.
Yeah.
100% wrong.
Yeah.
Because people had fixed in their mind New York City, where the death rate was higher. I mean, actually, we know from seroprevalence studies that it was higher. The actual infection fatality rate was higher in New York City. So now, since then, 50-some studies from around the world have been done, and there's a consistent theme. The infection fatality rate is somewhere between 2 and 3 in 1,000, just like what we found in Santa Clara, just like what we found in LA County, and the places that have higher density, where you think did worse, Bergamo, New York City, they did worse. Their infection fatality rate is worse, 5 in 1,000, 6 in 1,000. In some Spain, maybe 10 in 1,000.
So, okay, there's a lot here. And again, this gets me fired up because I've been talking about this myself. Why would an infection fatality rate be different in, say, a New York versus a Santa Clara? Walk me through that.
Yeah, sure. So we think about infection fatality rate as if it were just a
static
feature. Yeah, well, it's as if it's the virus itself. It's a feature of the virus. Here's the virus. Here's what's infection fatality rate. That's wrong thinking. It's a function of the virus, obviously, the biology of the virus, but also of the host, and also of the healthcare system taking care of the patient.
Do they survive? Do they get care?
All three of those things matter a ton. So, for instance, if you look at the case fatality rate for this disease, just case fatality, forget about infection fatality rate. This is the number of people who had the disease who actually died from it. It's declined very sharply since March and April.
Sure has.
As the
cases up, deaths down.
Has the virus changed? Maybe a little. I mean, there's some mutation, but not enough to think that it's had any appreciable change. Yeah. What it is a few things. One is the set of people that are getting infected are less vulnerable to it.
Yeah.
They tend to be younger, and so they just don't die at high rates from it. The second, we were better at managing, better at treating it. Right. So the
dexamethasone.
Exactly.
Not intubating everyone.
Not killing people with ventilators. Right. I mean, that seems like a really good idea.
Yeah. Which by the way wasn't clear in the beginning at all. So not to disparage people who are intubating everyone, but we just didn't know.
Yeah. No. Yeah. Look, I have a lot of sympathy, and people were really brave going in when we didn't have the numbers. I honor that absolutely. Yeah. But it is absolutely the case. We've learned a lot about how to treat the disease,
right?
And we're much better at managing it than once were,
right?
I think that kind of news ought to get out more, right? That seems like an important fact. Our understanding of the disease shouldn't be frozen in amber in March.
So you're preaching to the choir, because I just did a video on this, on cases up, deaths down.
Yeah,
I actually think that there is a lot of catastrophization and misunderstanding, and there's been a polarity that I've not seen in science ever. And it shouldn't be. It should be looking, and the thing is, folks like you, and this is the thing, I criticized your trial as well, but also put it out there and said, hey, this is what's going on, this is a critique, et cetera.
Well, science, that's how science works.
That's what you do in science.
I mean, I didn't mind the science.
Right.
I mean, of course, we look at the data, we try to interpret it. That's what you're supposed to, I mean, that's the fun part of science.
But the vitriol and the censorship too, like Ionita's your partner in that. One of the most respected scientists actually has done papers and papers and papers on how we get science wrong with our own biases, right? Was accused of severe bias and censored.
Yeah, I mean, it was absolutely shocking. So like BuzzFeed attacked my family. From BuzzFeed.
Can I say, so anytime I see anything in BuzzFeed, if it isn't 10 reasons celebrities have done something that make you go, what? I'm shook, I don't listen to it because it's so clearly biased.
Yeah, this was, I mean, it was really kind of,
BuzzFeed attacked your family.
Yeah, so my wife was involved in like my daughter actually volunteered as a it was a lot of community involvement. The feeling around the study in Santa Clara was a lot of volunteers, a lot of people. It was a really good feeling, right?
Yeah,
so and my wife was super excited about the study. She's an oncologist. She wrote an email and to her friends encouraging them to sign up. And somebody leaked the email, which had some information that was not quite right, and then to BuzzFeed, and then BuzzFeed made her international news.
Oh my God!
Which was, I mean, that's the hardest part of this. Is just getting my family involved with it in a way that I didn't expect.
What What's the agenda for that? That you're somehow minimizing the pandemic and going to cost lives? Is that their angle?
I think so. I think that's part of. I mean, so there were other the same BuzzFeed author then wrote an accusation that somehow because people gave money, including I guess a JetBlue executive, to Stanford.
Right. $5,000.
5,000.
So which is a rounding error on the cost of a trial.
Well, in this case, the study we ran it really cheap. It was less than $100,000 for the study.
Nice.
They gave the money to Stanford, and somehow I'm going to change the result it's just ridiculous.
You know what? Jay, when you're in big JetBlue's pocket, anything goes.
It was really kind of him to give money for the study. I'm grateful.
And that's fine that he had his own agenda, which was probably, hey,
everyone has agendas.
Everyone has an agenda.
Right? So, my agenda was to learn what that number was.
Right.
And I think we now know it. Right.
So your feeling now is it's somewhere between 0.2 and 0.3% infection fatality rate.
That's the median around the world.
Median around the world. It may be higher in places like in New York. Yeah. Why was it higher in New York, do you think?
I think there's lots of reasons. I think potential. One is I think the set of people that were infected in New York were older.
Yeah.
And the institutions where they were infected are less capable of dealing with it in the early days of the epidemic. Right, so there's something to this, and the fact that it was older people in nursing home settings that weren't sort of equipped to manage it.
Right.
I think that played a big role in why it was higher in New York. The other thing is I think there's, and this is a theory I've seen. There's something to it. Like when viral load is higher, when you're exposed to it multiple times over and over again, you just get a worse outcome.
So I talked about this with Monica Gandhi yesterday on the show, UCSF ID doc, and her theory of viral inoculum correlating to severity.
Oh, I saw that.
Yeah. And she actually posited the same exact thing it's a theory, like there's a hypothesis.
Yeah.
In New York was that people are in the built environment are on top of each other, especially minority communities, which were hardest hit. And so as a result, if you're out in Queens or somewhere, and you're just living in this multi-family home, told to stay indoors, right? What are you doing? You get a high viral inoculum. And so that's, again, it's a hypothesis, but it's interesting because that would affect your infection fatality ratio if that is a component of how severely ill you get, correct?
Yeah. And I think it also explains why nosocomial spread, like hospital spread, is so
exactly
so important here. Right?
We talked about Dr. Lee, the guy in the ophthalmologist in Wuhan who first sort of broke this news, and he died and he was 33. And the thought was he's an ophthalmologist, so he's seeing patients this close to their face getting viral inoculum right in the face. Yeah. So, and now we've learned a lot from that. That's why we N95 and face shield in the hospital and PAPR and all that.
Right.
If we can. Yeah.
Right.
Yeah. So do you think the infection fatality ratio, if you just looked at one community, like say Latinas, would you think it'd be higher there from what we're seeing?
From what I've seen, I think that minorities are harder hit with this epidemic. That's absolutely true. So Black communities, Latino communities are a bit harder hit, especially in California. Latino communities make up the bulk of the deaths.
The disease, 45%.
Yeah, it's incredible. I don't think the infection fatality rate.
Sorry, 60% of cases. Yeah,
it's
in California.
Shocking,
yeah.
Right? But I don't think that the infection fatality rate is much higher, conditional on getting it. It's just they're more likely to get it.
I see.
But it might be a little higher. It's hard to.
You have to see because is there pre-existing disease more in that community? Chronic disease, diabetes, hypertension, disease, poverty.
That's the question, right? So if you have these underlying conditions, of course you're more likely to die from it. If you're older, you're more likely to die from it. Things like that we know for a fact.
Right.
Once you control for that, if you're Hispanic, are you more likely to die? That probably, my guess is probably not.
Interesting.
I think it's mostly those pre-existing conditions and the fact that you're more likely to get it in the first place.
Now, one counter proposal I might say is, well, if viral inoculum does matter, if that hypothesis is true, and Hispanic families are more likely to congregate together under one roof, you might see actually a higher infection fatality rate in that group.
It could be, yeah. There's a study that was done in Mumbai, in the Dharavi slums in Mumbai.
Yes, I saw that. Explain it.
The prevalence was enormous. I think it was like,
it was like 80%,
yeah,
or 60 or 80.
And I actually talked to some of the study authors, the studies who ran the thing. Essentially, the idea they have is that the lockdown put people, this is a slum where 10 people live in the same house.
Yeah.
and there's police walking around making sure that if you walk out of the house, you're gonna be arrested. So if they put 10 people in the house, they probably spread the disease with the lockdown with an enormous viral load. You can see with the 80% antibody number, right?
Right.
But the infection fatality rate was really low.
It was minuscule.
Yeah.
Like I think they report now, it might be an underreporting to some degree, but like 200, 300 deaths out of all
that.
Yeah,
it was really
tiny.
low. So part of that is they don't have the diabetes, they don't have the obesity, they don't have those kinds of predisposing conditions.
Yeah, because they're thin
and they're younger, right?
They're younger, yeah.
So I think we're still learning. At least I'm still learning quite a lot about the disease.
Well, and the other thought that I had, and again, this is just pure mental masturbation, is the idea that group may be exposed to so many pathogens on a daily basis, including coronaviruses, et cetera, that they have some innate T-cell immunity or mucosal immunity, something that we don't have.
Yeah, no, I think there's some evidence of that even in the United States, right?
Yeah, exactly.
I saw this really interesting study where it looked at, it was a small study, so I don't know if it generalizes it will hold up when it's done larger, but people who have young kids, if you have young kids, I have 3 kids, and when they were little, I had colds all the time.
Yep.
People who have young kids are less likely to die from it.
And that really tells you something. Like I remember I had a severe cold actually just in January before it was really widely prevalent. And I never had antibody testing or anything, so I don't know if it was COVID, but I doubt it. No one else in the family was sick. I caught it from a friend who was in Las Vegas. And I wonder whether getting those really jazzes your T-cell immunity, kind of like getting a BCG vaccination or something like that.
Yeah, I think there seems to be increasing evidence that T-cell mediated immunity does matter quite a bit.
Yeah.
But
even talking about that, people are like, well, stop minimizing the catastrophe.
I don't understand this. I don't understand. Like, this is not politics to me.
Yeah.
This is a really important epidemiologic phenomenon that we absolutely have to get our hands around. We need the best science possible. I don't understand the politicization of you're on team apocalypse or you're on team doom, right? Your team
denial.
Yeah, exactly.
I like that, team apocalypse versus team denial. Yeah, go. That's really what it is. And it's we say that we don't understand it, but we do understand it. It's an election year, all that. But as scientists, we don't condone it, is what we're trying to say.
Yeah.
You got sucked into it, right? Because by definition now, you're on team denial because you did science that doesn't support the press narrative of X, Y, and Z.
Yeah, I think what I was taught in sort of in public health circles, we actually give people the right information, the true information. We don't unduly stoke panic,
right,
just in order to get the result we want,
right,
which is essentially you're going to comply with this order or that order,
right.
We don't do that. We tell people, okay, here are the risks, here are and people are we have to trust people to react to that appropriately. Not many times they won't,
right,
but many times they will.
Right.
But on net, if you want to maintain trust in the public health community, the absolute first thing we have to do is tell them the absolute truth about what we know and what we don't know.
So what you've nailed here again is something I talked with Vinay Prasad on the show about, which is authenticity. We suck at it in medicine. We prevaricate. We think we don't trust the public to do the right thing. We are paternalistic to a fault. So when Monica was on the show yesterday, she said, I'm an HIV researcher. I believe in harm reduction. How dare us preach at people, wear a mask, you dummy, you stupid person, and do you want to kill grandmothers and this and this and this? That's not the way to communicate public health. You communicate the uncertainty, but you communicate what we know. And her whole thing is, well, if mass reduce inoculum and it's a low risk intervention, then maybe you guys should do that, right? But it's your decision. I don't want to mandate it. And if we get 80% compliance according to our data, maybe that's a tipping point. But again, it's a hypothesis. So,
I think I'd amend that a little bit. So I agree with that actually. But the only thing I'd amend is it's related to the harm you really, really are seeing, right? So if we really are seeing it's a 3% mortality disease, then I'm okay with more
draconian,
aggressive.
Yeah.
But if on the other hand we're really uncertain about that 3%, which we were, if we really don't know, we should tell people, look, it's looking like 3%, but we don't know. Let's see. Here's what we're doing to try to figure it out.
Right.
We should just be honest about what we don't know. I think that's, to me, has been the most shocking thing, that the public health people and doctors have donned this mantle of absolute knowledge in a place where I've read a lot of this literature. There's a lot I don't know, even though I've been reading the literature scientifically, right? So we just don't know. We should say that. Why is it bad to say that when we just don't know?
And what it does, there's a side effect of that we're seeing now, which is when doctors and public health officials say, don't wear a mask. And then in the next breath, wear a mask of any kind. I don't care if it's just lace panties over your face. Wear that. We look like idiots. And on top of that, the public then, which isn't as dumb as they're portrayed by the intellectual elite, goes, now, wait a minute.
Yeah. And they should.
And they should.
Yeah.
And then what happens is, and you see it in the comments to my own videos, right? If I do a video kind of leaning in one direction, 1 billion people comment the other direction. If I lean in that other direction, 1 billion people comment it. The public just is trying to find truth, right? Yeah. And it's tough.
And I mean, that's okay. Like, we're having a conversation. There's stuff I'm learning from you. I hope there's some stuff you're learning from me. And we basically, that's what science is. It's a conversation that leads to more data, that leads to more conversation. That's what it is.
So what you just said is absolutely reasonable and rational, and BuzzFeed attacks your family.
Yeah. So, I mean, that was tough, I have to say. I mean, that was probably the hardest parts of the whole work on this, was just feeling like I've dragged my family into something. There's one thing to go after me. It's another thing to but in any case, like, let's leave me aside. So we put this paper out. We find this number, 0.2 to 0.3. And then a whole series of studies start coming out from around the world to find the same number. Many of them published. The peer-reviewed literature, I think, now has established it.
So let me ask a question though. So what? 2 to 3 times a flu is still catastrophic, man. Well, how do you respond to that?
No, it is. And there's also, I'd amend that. There's also no vaccine.
Right, no vaccine, and we didn't have treatment.
Yeah, absolutely. Yeah. It is worse than the flu for those reasons.
Thank you. Because I think that the denial of, I think a lot of people perceive this comparison with flu as very charged. And the truth is,
it's worse than the flu. And I think for older people, it is absolutely, we should treat it like it's much worse than the flu, because it is worse than the flu.
It is, yeah.
So for instance, nursing homes, right? So I just looked at a paper that said that nursing homes often share staff workers.
Right.
So like one staff worker works in nursing home A, also works in nursing home B. We should be using our testing resources to make sure that when shared staff workers move back and forth, they don't bring the virus back and forth with them across these nursing homes. That seems like a completely reasonable outcome of the fact that older people are much more vulnerable, especially people with comorbid conditions.
And you've been a big advocate of protecting vulnerable groups.
Yeah, that's the whole point of this is to learn who really should we be using our relatively limited resources to protect, and when we raise alarm, who should we be doing it for? There are costs to raising alarm, right? So like if I panic you may take actions. That's the whole point of the raising the panic and the alarm. But those actions will have very little effect, or much less effect on the spread than the costs that you pay and society pays for those actions.
And the problem with those costs are they're often intangibles. Like I have had fans who've become fans of my show since we started the COVID adventure. And the reason they became fans is they have generalized anxiety disorder, or they have some level of anxiety. They have been jumping out of their skin watching the press catastrophize about this and generating the fear that I think was the medical establishment was complicit with, because they are seeing it on the front lines in a very biased way. Oh my God, my ICU is full of people who are dying, including some young people. And therefore, anything we can do to get the public to behave is going to be important, right? And then what ends up happening is these poor individuals who have a tendency to anxiety are losing their minds. So they tell me, I watch your show because you seem rational and you have opposing viewpoints and you're not just saying we're all going to die. And I think, why should I be the one who's doing that?
Well, you have a good audience. I mean,
yeah, but that ought to be the general.
I agree with that. I mean, I think I don't really understand it, but it seems like people want, especially the press, seems to want to create this panic. So every time there's a study that comes out that a child has died, which has happened absolutely from this disease, you're going to get this panicked headline from the press. Now, one of the things I've learned from the seroprevalence studies, again, from around the world now, not just mine, is that there's a very wide range of clinical presentations from this disease. It ranges from, somewhere between 30 to 40% of the people that get it have no symptoms whatsoever. They can't remember. They have the antibodies, but they have no symptoms that they can remember from it. Even, so maybe even a larger part have relatively mild symptoms. It's like a cold to them.
Right.
And a small fraction have this horrible viral pneumonia that kills them, right? We focus all our attention on the viral pneumonia and none on the fact that 998 people are going to recover from it.
Yeah,
out of 1,000.
That's a feel-good hit of the summer right there. Like, that's a positive story. And they're going to develop immunity. And this whole panic about, well, no, we're never immune. That's another press thing.
Yeah, it's insane. Ridiculous. Like no other virus does that, right?
Exactly.
Yeah.
Well, what do we? Oh, and the related piece to that, like you said, one story about a child,
HIV, I guess.
HIV. I guess strep throat. You can't have a vaccine.
Yeah. So it's like I said, it's a legitimate scientific question, but it's one we now have an answer to.
Right.
You do develop immunity to this virus.
And the thing is, because we have now millions of cases. And we can look, and there's been I think 2 documented cases of actual reinfection.
Yeah.
One was it was totally mild. The other was more severe.
Yeah.
And so you could think in a population there's variance, right?
Yeah.
But still.
Well, 2 out of millions, right? So,
Yeah.
And as you said, the first case that was a reinfection, it looked like the guy was protected.
Mild, which is what you would expect, even with a cold. You get a cold one year, you may get it again the next year, but it's going to be minor, mild.
Yeah, if it's the same virus, even if the antibodies fade, you may have T cells or other mechanisms of immunity that make it so that not that you won't get sick, but you'll get sick much less. It won't create a severe severe illness.
Now, one thing that's going to come up, and this comes up a lot again in the catastrophization camp. But what about the long haulers and the terrible damage to the lungs and the cardiac damage and the brain damage and all the other things?
Those happen with influenza.
Exactly right.
So my son, my young son, 13-year-old now, a couple of years ago got the flu. Now he'd had the flu vaccine, and he still got the flu, right?
Which happens.
Yeah, it happens. Yeah. And it was fine. Like it was a little worse than I thought you normally would get, and he was getting better. And he woke up one morning and he couldn't walk.
Oh my gosh.
I was going through all the panic things that when you go through medical school, you always have
you're like Guillain-Barré. That's exactly
transverse
myelitis, right?
And I'm like, oh God, so it turned out it was a benign myositis. Thank God. And within a week he was walking again. Flu has all kinds of strange side effects. It has neurologic side effects. It can have cardiac side effects. We put these in context, right? These are things that happen, absolutely can happen. But we have a lot of information about how frequent they are. Are they likely? How long lasting they are? If it was Guillain-Barré, it would have been terrible.
Yeah.
If it's benign myositis, it lasts a week and he's okay.
So it's funny because my daughter had a viral syndrome when she was 3 and couldn't walk, and again, benign myositis. Yeah. And but again, you go through the panic. But the point being, these things happen with viral infection. This is a new viral infection that we don't have a vaccine for, that is novel to the degree that it's novel, although we seem to have some innate immunity from cross-reactivity to coronavirus. And yet we are spinning it as if the world is ending. And the thing is, that would be fine if we thought it was actually going to cause less harm to spin it that way than not. But it's actually causing a lot of harm in terms of the response. So whether it's suicide rate going up, substance abuse, economic catastrophe, mortgaging our children's future, creating intergenerational divides now.
Yeah, I was hoping we get to talk about that because that's something I think has been vastly underemphasized. And it's breaking my heart. So let's talk about suicide.
Yeah.
The CDC released a report, I think in July, it was a report where they ask about suicidal ideation, like how many suicidal thoughts have you? Have you had any serious suicidal thoughts? 1 in 4 18 to 24-year-olds, 1 in 4 18 to 24-year-olds in June had serious thoughts of suicide.
So my assistant is in her early 20s. And she only just recently told me during the early lockdown stuff, we didn't have her in our house and, kind of kept her on not a furlough, we were paying her, but she isolated. Now, this is a hypersocial person in the prime of her life who is now told, don't leave your house, just sit there with your dog. And she told me now that it was so awful for her, you know?
Yeah, for a disease for her, early 20s, probably 1 in 10,000 death rate. I mean, IFR. I mean, we're basically asking young people who are meant to live in community. Not me. I was a hermit, but everyone else.
Me too. I really enjoyed this.
But but you know, we're not meant to live alone in our house, holed up. It's going to have consequences. It's going to have severe negative consequences psychologically, and we're already seeing it. So I mean, I think, but that is just the beginning of the cost of the lockdown. Worldwide, there are reports of hundreds of millions of additional people starving as a result. Because you know, you talk about economics. So one of the themes that I've heard argued against me when I make this point is, well, look, you're talking about the lockdowns, and there's some economic costs, but what are they relative to the lives we save?
Right.
But it's not lives on one side and economy on the other. The economy is really important to the lives of the people who are in the midst of it. And if people there are hundreds of millions of people around the world that are on the edge of economic disaster, and you push them over, you destroy the world economy. It's not just dollars; it's hundreds of millions of people starving, and that's what the UN has said. I mean, the UN is finding support.
And right? I said this like in the first month of this pandemic. I said, you guys seem to have this false dichotomy between economy and lives. Blood is treasure. It's a transitive property. When you start having unemployment, the suicide rate goes up. In the world, when you shut the economy down, people starve to death. And this idea, and I'm going to rant for 1 second, and you may or may not agree with me. I feel like my own tribe of people, the healthcare professionals, have held the rest of our country hostage with their catastrophizing around this, which was done with good intent. These are good, smart people, and they're right. We've had deaths and terrible outcomes, but they fail to see the bigger picture. And Monica Gandhi on the show yesterday said, as doctors, it's our responsibility to see the bigger picture.
Our job is to show people that picture. I'd say it's even more than just, I mean, I call us the Zoomocracy. I mean, and I'm in it, right? So like, I'm fine. I can be on Zoom, and I'm not going to lose my, well, maybe, who knows, Stanford will keep me on.
Oh, we got to talk about that. Yeah.
But I think I'm fine, right? So like, why should I care about? Well, I mean, my job is to tell people what's happening in the rest of the world.
Right.
I think.
Yeah.
You know, there's this program called Gavi, which is a program for vaccinations, international program for vaccinations. They've halted.
Yeah.
Their operations because of the lockdown.
So polio comes back. Measles comes back. Yeah. So it was never gone. Measles is still here.
Yeah, we're going to see a resurgence. We may even see a resurgence of polio in the United States, because people stopped taking their kids for the Tdap vaccine.
Yeah, absolutely. Cancer screening, mental health.
We're going to see. So we've had good news from cancer for the past few years. We've actually had decreases in cancer-related mortality for the first time in my memory, anyways, for 3 or 4 years in a row. That will reverse. We're going to start seeing later stage breast cancers, later stage prostate cancers. People stop getting screening. People actually even stop getting treatment for cancer, active cancer. During the epidemic.
I've seen that. HIV patients are losing their viral suppression. Monica was talking about that because they're not coming in.
Tuberculosis, millions of extra tuberculosis cases. Because tuberculosis you have to treat over a long period of time with regular antibiotics. People come in around the world because they're
directly observed therapy, all this other stuff.
Exactly,
yeah. Mm-hmm.
And people that stopped. We're going to see a resurgence of tuberculosis deaths.
Well, so let me ask a question, because this is very gloomy stuff. Like, honestly, you said earlier you were heartbroken. This is what keeps me up at night, because, here we have this platform. We can get this, like you said, we're part of the Zoomocracy. Like, we can do this, we can get this information out, but it doesn't sink in. And what it does, I worry that it even contributes more to this polarization, because there are camps that get so emotional about the damage we've done from our response, and camps that get so emotional from the United States' perceived failure relative to other countries in terms of mortality per million.
Well, I'm heartbroken on both. I mean, I think we in public health need to balance. COVID is not the only threat to public health. We need to understand that there's all kinds of public health problems.
So what do you think? What do you think you would say the United States should do? And then I want to talk about Sweden and Europe and Asia too. But what do you think the United States should do? So here's the problem. All this disaster from our response, and then the danger of the virus, which is worse for the elders and people with comorbidities, and it's less than we thought initially, and we have a little better treatment now. So what should we do?
Like if I had to characterize the American response, it's exactly backwards.
Yes.
We have quarantined the healthy and we've exposed the vulnerable to the disease.
That's it.
Yeah.
And Monica said yesterday.
Let's flip that around for me.
Monica said yesterday we were exactly backwards as well. We've favored the rich people who can survive this, the Zoomocracy like you and I, and we've punished the poor. So we've actually told them, stay inside, lose your jobs, get $1,200 a month.
Yeah, or you go out and expose yourself, deliver the groceries to me.
Essential worker.
Yeah, I mean, I don't understand it. I mean, now I could understand 3 in 1,000, 3 in 100 death
Different
rate.
story.
Different, like you could imagine, but even there you'd want a focused response on figure out who really is really
in
high.
that 3%.
Right, exactly. Or and there may be people who are less vulnerable. I mean, you tailor your strategy around the numbers you're seeing.
Yeah.
But we haven't done that.
Yeah.
We've gone the opposite in many ways. I think New York is an absolute disaster. New York, I mean, the highest death rates in the world happened in the Northeast early in the epidemic of the United States.
Yeah. And multiple reasons for that probably that will become clear also more in retrospect. And our retrospectoscope is going to be highly indicting, I think, of a lot of behavior that we had earlier. Yeah.
Can we return to you were asking me earlier about like the scientific discussion around this? Can we return to that?
I would love to.
So I've been really concerned about censorship in science around this epidemic.
As have I.
Yeah. So like you mentioned, John Ioannidis, one of the foremost physicians in the world, researchers in the world studying. I've had the honor to be able to work with him. He did an interview early on in the epidemic that was suppressed by YouTube.
How do you suppress John Ioannidis?
I don't know. I don't understand it. My view of science is that it's a conversation. We have to have the ability to express views that are not popular, or else we can't have a science. We can't have science. So the idea is that somehow if somebody is expressing a view that is contrary to somebody's interpretation of some public health organization, World Health Organization or whatever, it's ipso facto dangerous to say those views. That is a form of population control. That's what it is, right?
It really is, yeah.
And it's fine. Okay, if you know with 100% scientific with certainty that some fact about
is wrong.
Yes.
Yeah. Like vaccines cause autism.
Right. So what's the right response? You say, look, the vaccines don't cause autism.
Right.
That's the right response.
That's right.
And here's the evidence.
That's right.
If you have a situation of a new virus where the science is emerging rapidly and we're learning new things, I've changed my mind about 15 things about this virus as I've read new papers.
Me too.
Over the course. How could you not?
Oh, yeah, but you know what? Read the comments in my videos. You flip-flopped on this 5 times.
I mean, there's new evidence coming up, right? So
yeah.
So in that context, scientific censorship is criminal.
Yeah, I agree.
So I think, and we've seen this over and over again. There's a paper by a set of papers by this scientist Gabriela Gomez on the herd immunity threshold.
I love her work. Yeah.
And what I've seen her write is that she sent her paper to scientific journals. The editors won't even send it out for review because they're saying that it's too dangerous her findings suggest a lower herd immunity threshold. Now I don't know if it's right or wrong.
Doesn't matter.
Yeah, let's just have a scientific conversation about it. Like that, why is that so dangerous to talk about that you wouldn't even send it out for review?
I mean, the last time we did stuff like this, it was the Inquisition and Galileo was standing there.
I felt a little like that at Stanford.
Yeah.
I mean, I think well, we'll talk about that in a bit, but I think the knee-jerk reaction to censor people you disagree with inside the scientific community has been absolutely terrible. One of my Stanford colleagues actually wrote a New York Times article arguing for essentially a censorship board for articles that are not in open science.
Hey, look, I kind of am an expert in misinformation management. I have always I remember those Bakersfield docs? they were proposing some similar ideas to what you were saying, but their data was a little, and they were clearly a
I've
little.
talked with them. I mean, look, there's stuff I agree with about them, stuff I don't necessarily agree with them. But why should we not? Should they not be part of the conversation?
Exactly. So when that video came out, 1 million people sent it to me. What do you think of this? And I said, well, let me do a show on what I think. I agree with them that lockdowns are harmful. I agree with them we're overreacting, creating fear. I disagree with their use of the data on this and this and this, and I disagree that YouTube pulled their clip.
Yeah, it's ridiculous.
Why would you do that? All you're going to do is also just solidify this idea that there's a conspiracy.
I mean, I think the idea that media organizations or Stanford has some obligation to censor opposing views is absolutely anathema to science.
And my wife is on a listserv at Stanford. So a bunch of people that I know at Stanford got on a listserv on the Stanford listserv email and said, "We hereby disavow Scott Atlas."
Oh, that's disgusting.
Yeah. So can you tell me a little about that?
Sure.
Because,
so yeah, and a lot of my colleagues signed that letter too.
Yeah.
People I respect.
People I respect and know are on that list.
I mean, people I love are on that list. I mean, like friends. I mean, I disagree with them about some of the things.
Right.
But
we can love people and disagree. That's the difference.
Absolutely.
Without shutting them up.
Yeah.
Right.
So I think. Dr. Atlas, Scott, is the special advisor to the president on COVID. He has certain views about the nature of the epidemic. They're actually closer to my views than my colleagues. So among those views are things like the disease is less dangerous for kids, less dangerous than the flu for kids. That seems like there's solid scientific evidence, and yet the letter doesn't seem to. It seems to like paint this picture about the danger to kids. I think my colleagues are just wrong on this, where they disagree with Scott on this.
I agree. When I read the letter, I'm like, these guys are just wrong. They haven't read what Scott is saying. Now, look, I don't agree with Scott on everything.
So now, I think they've also mischaracterized what Scott has said. So, for instance, Scott has repeatedly said that he's not in favor of a herd immunity strategy. Actually, we should talk a little bit about herd immunity.
Herd immunity strategy. Yeah.
What does that actually mean? Herd immunity means that. So when we think about herd immunity, we think about it as a single number. But again, just like infection fatality rate, it is not a single number. What herd immunity means is that when a new person gets the disease, how many people are they going to spread it to?
Yeah.
If it's less than one, then you've reached herd immunity.
Herd immunity, yeah.
Right? If it's
going to be squashed. Yeah.
Exactly. If it's more than one, then you get more sort of this exponential growth, right?
Right.
That happens with every disease where immunity actually happens. That's just normal.
Yeah.
The number is a function of how people interact in society. So if I interact with a lot of people and I get it, I will spread it. If I'm sort of more fearful about the disease and I'm spreading it, then social distancing happens. Then herd immunity. You could get lower herd immunity thresholds because one person getting it doesn't spread it to a lot of people.
Yeah.
Right? So it's a function of the behavior of people as well as, again, the virus itself. It's not a single number where you say, okay, here's we've reached it. And ironically, you can reach it, cases are declining, and people stop taking those precautions and it goes back up again.
Right.
We go in and out of herd immunity.
Right. Auto-regulation, homeostasis of the population's behavior.
Yeah, exactly.
Right.
So that's actually, so it's more complicated than that.
That's right.
I have heard, personally, Scott has told me, I've never told the president that he's in favor of herd immunity strategy.
Yeah.
He is not. He's specifically said that. Yet the letter my colleagues wrote accused him of that. Just falsely. It's just he set up this straw man where I don't understand it. It's like they weren't listening, and partly it's the press's fault. Like the press has mischaracterized him as well.
For sure. So this is what I think happens, and you can correct me. They read the press, they read some CNN, MSNBC piece. Scott Atlas knows nothing about science, and he's got a president's ear.
He was the chair of neuroradiology at Stanford for years. I mean, it's absolutely shocking.
My wife worked with him, right? And the thing is, if you hear him talk, again, he's reiterating some of the concerns that we have. He's never said, let it rip through the population and develop herd immunity.
That's the exact opposite strategy that I know he's been telling the president.
Right. And the thing is, you've talked to him. Have these colleagues talked to him? No. And this is what happens. You have in group, this is his tribe of people, now excommunicating him and witch hunting him, because that's what's happening on social media. That's what's happening in the halls of academia. Is this how you manage? Okay, just play with this for a second. What if you're right and Ioannidis is right, and in retrospect we realize you guys were actually banging the right drum, and these people who censored you were wrong? Okay, that is going to be a criminal act that they did that cost lives.
I mean, I think there was an attempt to cancel me, right?
For sure.
I don't actually care. I get canceled. I mean, what I really want is the data to drive the policy.
Yeah.
That's what I really want. And
Yeah.
I think Scott would say the same thing. I mean, it's not personal for him. It's like, let's let the data drive the policy, because the costs on lives are high on both sides of this decision. There's no riskless option here.
Right.
So whether you lock down or don't lock down is not okay, let's just stay safe on one side. So that my colleague started a letter with the principle of do no harm.
Yeah.
How do you do no harm in this situation?
There's plenty of ways to do harm. Censor a colleague.
For instance.
On insufficient information.
Yeah.
Now I imagine, okay, so let's dig into that a little more, and you can refuse to answer this if you like. Your own paper was attacked internally in an almost politicized way. It wasn't so much about, the science, and I was reading these things about the internecine drama at Stanford, and I'm like, I know these people. What are they doing?
It was absolutely shocking to me. I mean, I feel like my academic freedom was attacked. And I've been at the university for almost 30 plus years, actually.
Yeah.
The motto of the university is let the winds of freedom blow. I don't think that they've acted, the leaders of the university have acted in that way toward my study. And I think that it's been absolutely shocking to me.
Are you tenured?
I am.
Okay, so you can say this kind of thing.
Well, I don't care if I lose my job.
You know what? I'll hire you. We could be like, we could have one of these like Sunday morning.
It's been really enjoyable talking
PBS shows. It would be really fun. No, so to this thing, I was shocked when I saw how this thing was played out, and I knew that what the press was reporting wasn't the full story. It was still concerning. I was like, well, is there a lot of bias here? Is this thing, And so I was waiting to talk to you about this, and at some point I'll have one of the colleagues that's attacking you guys on the show and see what they think, because it'd be interesting, right?
Yeah.
But I would love to see that play out in a way that isn't just politicized, because it's just,
Yeah, I mean, I think. So I got to do a debate with Stan Vermond.
Oh yeah, I know Stan. I know of Stan.
Yeah. So Stan. So it was really interesting. Like he's a Yale head of the public health department at Yale.
Yeah.
Really sweet guy.
Talks really slow. I was listening to your debate going, oh my God, I got to put it up to 3x.
Okay, well.
Except when you talk, then I have to slow it down.
Okay, dude. I'm sorry.
No, I love fast talkers.
But I think the thing is that he's open, right?
Yeah.
He wants to talk. He wants to have a conversation. I wish we had that spirit at Stanford.
Yeah.
I think in some ways we have lost that.
Yeah.
And it's been dispiriting for me.
Yeah, I agree. Well, the two folks that I interviewed from UCSF, Monica and Vinay, are deeply embody that spirit of open discourse. They may politically disagree. It doesn't matter. They only want to have the conversation in a polite and civil way.
Yeah, I mean, that's the thing. I mean, I don't think. I mean, so I don't know what John Ioannidis' politics are. I have literally no idea.
Right.
I don't, and I'm pretty sure if I were to talk with Iran, that we would disagree about politics.
Right.
It doesn't matter. We're doing science.
Right.
Like what we move to what the data tell us.
Iran Ben David, who was also a resident when I was an attending there. I'm going to try to have him on the show later.
Yeah, and he was the lead author on the Santa Clara study.
Yeah, so I can dig in a little more with him. Yeah, it's great to be next to all these smart people, But so it's been just a mess. It's been hard, I imagine. It's been hard on you, clearly, you and your family, but that's secondary to the thing that it's been hard on our scientific advancement and understanding this virus. Because when you suppress these ideas, what happens? They pop up on Twitter in a weaponized form. So now you have frank anti-maskers that are taking masks and ripping out the lining so that they can do the hygiene theater without the actual filter. This crazy stuff. None of that would have happened if we'd just been open and honest.
Yeah, I mean, I think it's the same thing with the anti-vaxxers, right? So like
same thing.
You're actually, the funny thing is like well, we should talk about the vaccines. Actually,
Let's do that. Yeah.
But I think if a vaccine does come out and it's effective, the fact that the scientific community has acted in this way will create doubt around the vaccine.
Who's going to get it? 40% of Americans don't want to get it now.
Yeah, and because the scientific community very, very clearly seems politicized around this.
Mm-hmm. 1,000%. And remember in the early days of fear, when we were in the Imperial College sphere of influence and we thought 3 million Americans were going to die, there was not an anti-vax voice to be heard. They were terrified. They wouldn't open their mouth. They saw, because when push comes to shove, if there's a vaccine, they're going to be first in line to get it when you're afraid for your life. But then as this thing spun out, now they've actually been empowered in a way that we haven't remembered in recent memory.
It's because the scientific community has made fools of itself.
They've made idiots of themselves. Does it make you want to hit stuff and throw stuff? And I mean, because I get emotional about it.
I'm not built that way.
I forget sometimes that I'm talking to scientific introverts who have like Spock-like control.
I have Spock.
Whereas I'm the opposite. I'm just like, throw the table over and kill everyone.
Oh, well, when they were attacking my wife, but that made me
that's too much.
But but other than that, I still just want to know what the right thing to do is.
Right. Well, there have been things where I've gone back and forth because I'm not convinced one way or the other, and I will literally sit up at night going, I put out a video today saying this, and is it really 100% right? No, it can't be 100% right because we don't know yet. So am I doing more harm than good saying it? No, what's the harm reduction?
Zubin, you have to say what you currently believe, and then when you find new evidence, you change your mind, you say it.
That's the thing. So that's what it is. But it's hard. It's still for me. It's emotionally difficult because I tend to involute this emotionally. Whereas again, that's why I'm not a researcher. So if I were a researcher, I could have a little more, equanimity.
I mean,
meditation helps.
It's hard to
not enough.
It's hard to admit that you're wrong, right? That's just. But look, if you can't do science without that, because new data come out and you change your mind.
So let me ask a question. Speaking of data, so and I've been meaning to ask this of you. So you read an Atlantic article, all right, and it says, here's all the cognitive distortions that people who think this that we've shown in this thing. And it was actually the opposite version of what I've been saying, which is here are the cognitive distortions that we are showing that cause us to catastrophize and misunderstand the science on this. They were saying, well, here's all the reasons that America screwed it up and not taking it seriously and so on. And we have this terrible mortality rate and the high case rate and all that. And they would say things in there, just throwaway things like, and then there's Sweden's policy, which is folly. And they put a link and they wish they hadn't done. How do you respond to that?
I mean, the U.S. has higher death rate than Sweden right now.
Yeah.
More cases per million in the United States than Sweden. I to characterize Sweden as a failure seems like, they've made mistakes. So in the early days, I think
not protecting the elderly.
Yeah, in April, like they waited till early April to essentially protect the nursing homes in a serious way.
Right.
And I think that led to some of their higher deaths. But that's the same when the U.S. made the same mistake.
U.S. did the same thing. 45% of deaths were nursing home patients. 0.6% of the population. So. So Sweden actually took a very different approach. Now,
I think it's more consistent with what a democracy does in the context of these kinds of things, right? So the idea of the lockdown, we were copying what China did,
right?
Like this idea, but the
Wuhan
idea
style.
that we could do this militarized lockdown, I don't think is consistent with a constitutional democracy.
I agree,
and you're seeing this play out in places like Australia or Victoria, where they have this, essentially a very draconian lockdown. You can only go out for an hour. You have to, if you're going to go to a park, you have to walk alone. I don't think that's consistent. I mean, people will play with that for a while if it's a 3% mortality rate.
Sure.
But they won't put up with it forever. And that's a constraint on public health in a democracy. You have to take that into account. You can't pretend like, it's really unfortunate that people won't put up with this forever.
I said that in February. I said what we're seeing in Wuhan is absolutely never going to be feasible in this democracy. It's just not. And you could just say, well, then people will die because of that. But then that's the cost of living in a constitutional democracy, that you will not have that kind of control. And one thing I would say to that is life is to be lived. We don't live in fear of death or dismemberment every single second we're awake. And that's an ethos that I think is worth supporting. And again, that's a personal thing. I'm editorializing.
Yeah, no, but I think that's completely right. I think one of the unfortunate outcomes of this pandemic has been to train people to think of other human beings as just bags of germs to be avoided.
You're right.
It's going to take a long time to repair the damage from that.
It's a social dissolution. And then what happens now? We have, unrest on a massive level. I'm not saying they're directly correlated, but I'm saying they're directly correlated.
It wouldn't surprise me. I think the people are psychologically afraid.
Yeah, I am. Yeah. Monica, when she came yesterday, I said, you don't know me. And the reason she came was she wanted to talk to another human being face to face about things she cares about. And she hasn't been able to do that. Zoom is great from a technological standpoint. What a wonderful tool, right? I hate it. It makes me want to die. And the reason is I'm an extrovert, and being in the room with someone like you and I right now could not have the same conversation. No. I'm reading your body language in real time. It's a 2,000 frame per second refresh rate. We're able to talk over each other. It's a beautiful thing that humans do.
Yeah, and we're built for this kind of community. We're built for this kind of communication, and we are not built to be alone. Yeah. Which is essentially what this epidemic has done. And the public health community said, look, that's what you need to do.
So that's what you need to. They're telling you be inhuman.
Yeah.
And also now we changed my mind. Be inhuman in this way instead of how it was there. Well, let me ask you something. So you look at the Asian countries, because you can look. Okay. U.S., Sweden, UK, deaths.
Yeah.
Deaths. Then you get to European Union deaths. And then you get to New Zealand, Singapore, Hong Kong. Whoa, actual viral suppression.
Yeah, I mean, I think there's a few lessons to be learned for this. So New Zealand. Let's come back to New Zealand, because New Zealand is really super interesting on this front.
Yeah.
I think that some of the Asian nations that suppressed the virus, they caught it very early on.
Yeah.
When contact tracing, the kinds of things that we say are like the mantra of like test, trace, and quarantine actually can be effective.
Yeah, early.
Yeah. But by early April, 50,000 cases in Santa Clara alone.
It's out of the bag.
I don't understand why people thought that was going to work.
And how do you contact trace asymptomatic cases? You'd have to test everyone, hope there aren't a bunch of false positives. Yeah.
So I think that was a thinking mistake.
Right.
That the virus wasn't so widespread. We could use this strategy that seems like it was working in Asian countries.
Right.
But even in the Asian countries, I think there's some evidence that we talk about cross-reactive immunity. Like there were other coronavirus-like infections that they've had. Mm-hmm. They may have had some more extensive cross-reactive immunity than, or more prevalent cross-reactive immunity than the European countries and the U.S. had.
Right.
So I don't know the
SARS-ish.
Yes.
Ish. Yeah.
Who knows, right?
Who knows, right?
So I think we don't know fully why it didn't hit the Asian countries as hard. But I think it's important to think about. New Zealand is a really super interesting example. They famously suppressed the disease at 0 cases for 120 days.
Right.
And then out of nowhere, the cases start rising again. Okay, well, what did they do? They locked down again. The problem is like that lockdown is now repeated forever.
Yeah.
They're going to have to keep repeating the lockdown over and over again.
Or they'll just go through what we went through.
And they're an island nation that depends on tourism. I mean, fully, I think it was like 10% of GDP. It's a very large fraction of GDP. Don't quote me on the number, but that large fraction of GDP is gone. Basically permanently, because who wants to sit in a 14-day quarantine to visit someplace?
Right. Right.
And people leaving the island are also gone. So that's just the traffic in and out of the island is out. So you have as a continuous, and they've had a 7 to 10% decrease in their their GDP rate just this year. You don't keep that. You basically are. If you want to isolate yourself from the rest of the world, you can do it, but it's going to take you enormous. It's going to be enormous cost, and that is not an option available to the United States.
Yeah, absolutely. So the New Zealand experience is interesting because they are relying on something that may or may not happen, which is a safe and effective vaccine as their savior. Because what else could they be waiting for? Yeah. It's always going to exist in the community at some level. Otherwise, we have to learn to live with it. And their way of living with it is shutting down their entire island forever. But they're probably waiting for this finish line, right?
Yeah, they're waiting for the vaccine.
Now, what's the risk of that?
Well, so the vaccine is, I have to say that more progress and rapid progress has been made on the vaccine than I anticipated. If you'd asked me in April, would we be here with phase 3 trials actually ongoing for several vaccine candidates, I would have said there's no chance.
Yeah.
I mean, there aren't any human coronavirus vaccines.
Yeah. Paul Offit said the same thing on my show, vaccine expert.
Yeah. So
at that time.
Okay. So, but now here's the situation. We have these vaccine candidates. Many of them look promising in the phase 2 trials. The phase 3 trials need to be on large populations of people. Why? Partly because the cases and deaths are declining. Ironically, that makes it more difficult to show that the vaccine is efficacious because you just let's say you do a vaccine. Let's say you did the COVID vaccine before coronavirus came along at all.
Right.
Well, you'd never find it efficacious in preventing death because there was no risk of coronavirus.
Exactly right. Yeah.
So that's where
we're making it harder now. Yeah.
Right. So the decline of the cases and the decline in deaths makes it harder to show that the vaccine works.
Yeah. Yeah. And that's going to make it more difficult to show efficacy. Safety, we could still study.
Yeah. Safety we could study. And there have been some good news and bad news. Like many of the vaccine candidates have been safe in phase 1 and phase, but there are reports now. There's a transverse myelitis case.
Yeah, in the UK AstraZeneca. Yeah. Now that's a different viral model, right? Chimpanzee adenovirus. Yeah. So it's different than the mRNA vehicle.
But the mRNA vehicle hasn't really been used in human vaccines before. Ever.
Exactly. Right. So it's totally novel.
So I mean, it could work. It could still work. Right. I think I'm waiting. I mean, if the data show that it's safe and effective, I'll be first in line.
I'll be first in line. Yeah. I have to look at that data.
Yeah.
People have asked me, will you and your kids get this thing? I'm like, well, I'll tell you what, as soon as I am convinced that the data looks good, I'll go do it because I would like to get on a plane and go do things without thinking, well, I'm 47, so my risk profile is X. I have genetic clotting disorders, and so endothelial dysfunction. So my risk is somewhere in the X percent. That's how I calculate my own risk. So I take reasonable precautions, but I'm not crazy because I desperately seek human connection, and I'm willing to die rather than.
Well, it's probably 2 to 3 in 1,000 for me.
Yeah,
I would rather live my life with that 2 to 3,000 risk if I happen to get it.
Right.
Than to not.
Oh, but you're going to kill grandma by asymptomatically spreading it to her.
I mean, when I visited my 80-year-old mom, I wore a mask.
There you go. And that's what I would do with my parents. Yeah. So let me think here. What you just said is be rational, take risk personally and decide based on open data. Don't censor people. Let's have actual scientific discourse instead of name calling and politicization. And let's look at this thing with clear, open eyes and listen to all viewpoints. Is that about right?
I mean, I try to be controversial, Zubin.
Well, you've done a good job by proxy. In person, I haven't heard anything that you've said that makes me go, oh my gosh, that's so controversial. It's called being rational. Now, the thing is, I'll get criticism even during this interview that, did you really pound him on this and pound him on that? That's not my job. My job is to say, here is a guy who has a certain experience set that's very valuable. Let him talk about what he thinks. And you guys can then debate it in the comments openly. That's called scientific discourse. It's actually just discourse. And sometimes I wonder because anything I post, if I look at Facebook, for example, which is our biggest platform, 2 million people follow us there. If I put something there and you start reading the comments, sometimes you want to die a little because it's like the movie Idiocracy actually came true. And you just go, oh, and it's on all sides. It's all sides.
See, I get referee reports all the time for my papers, so I'm used to that.
You're used to it, right? You're used to it. Okay, we talked about Sweden a bit. We talked about New Zealand, and we talked about Asian countries and why they were different than us. We talked about the U.S., we talked about what we might want to do moving forward. So do you think cases are just going to continue to decline and deaths are going to continue to decline here?
I mean, there's 2 points of view, right? So one is that there's going to be a second wave. That seems to be the Fauci point of view right now. I don't see much evidence of that.
Right.
Like we haven't, so in the United States, for instance, we talk about if we had a second wave. We had New York and then a second wave. We didn't have a second wave. What we had is a regional epidemic. Each place has had a first wave. That's what it looks like everywhere. Now, it's possible. I mean, we don't know. The thing has only been around a few months that there could be one. But it's looking increasingly unlikely to me. But we will see. Yeah.
I'm with you. And I, based on current information, now I can be proven wrong. And I've said this to my supporters they're people who subscribe to the show and we do private live shows. There's like 7,000 or odd of them. And I'll tell them things that I'm not comfortable fully vetted out for the public. So I go, this is my feeling right now based on data is that there's not a second wave that in this classic sense. There may be a second wave case-demic where we start testing a lot and we see a lot of asymptomatic positive PCR fragments. The second thing is what people don't seem to understand is that the first wave, like you said, was a geographic thing where in a cooler climates like the Northeast, you saw a massive rise and then a fall. In more southern temperate climates is what you see kind of with influenza, which is a slower delayed rise and a low, long hump. And they're calling that second wave. That's still all part of the infectious pattern.
Yeah.
And I think in the winter, it'll be interesting to see also schools.
Yeah.
Tell me your thoughts on schools, because
I think it's criminal not to open schools.
I agree with you.
Yeah, I think we talk about safety. It is more unsafe to not let kids go back to school than to open up for school.
Absolutely.
We are harming kids in a way that is irreparable and immoral.
You're going to get a horse's head in your bed from the teachers union on that one.
I mean, look, I think a lot of teachers want to be. That's their vocation is to teach, and they want to teach in person. How do you teach a first grader to read over Zoom?
No, it's a crime.
Yeah.
And the thing is, they're doing the best they can. It's very, very hard. But this is one of the things that just gets me so upset, because it's a regressive tax on the poor. So you're saying basically that a person who depends on school for their meals, for their social interaction, for behavior control, because mom is a single mom and can't, and how is she going to work when we can hire nannies and assistants. They can't.
I saw a picture, I think it was in the San Jose Mercury News, of two kids sitting outside of a Hispanic kids sitting outside of a 7-Eleven with their little Google Chromebooks.
I saw that. Using the 7-Eleven, the Taco Bell Wi-Fi.
To Wi-Fi, because they don't have Wi-Fi at home.
That is disgusting.
It's terrible.
It's heartbreaking. Yeah.
And schools are not just simply places for teaching, although that is incredibly important, obviously.
You are Indian. I knew it. It's for teaching only, nothing else.
But they're also places where kids get their nutrition. Somewhere on, I think, on the order of a third of kids in the country have subsidized school meals of some sort or another. Like a lot of their calories come from there. It's places where they learn to socialize. The long run consequences of shutting that down are absolutely enormous. Even the short run, I suspect we'll start to see suicides jump up among adolescents because they're not. The school is good for their mental health as well.
I have a close friend who's a physician whose daughter was 12, 13, and during the lockdown started to exhibit just the worst anxiety. Like he would describe this to me, and it was hard. I mean, this kid was beside herself. And, to the point where it was medications and psychotherapy and all that. And he, affluent guy, so he can afford all this. And then school started, some little bit in person, some little bit by Zoom. And the anxiety started to evaporate. And we forget that we're these social animals, and especially kids. I used to look forward, the summer, as much as I love summer, you look forward to school starting because I'm going to see Joey and Chad and we're going to hang out and cause some crime, man. I mean, that was what it was like.
Yeah, I agree. I mean, I think for kids especially, that playtime is incredibly psychologically important. To deny them that seems, okay, it's one thing if they really were facing high risk.
So tell me about that, because the teachers will push back and say, "But there's teachers with chronic disease who are elderly who."
Yeah, I think we should take that into account. Like I think and different school districts should creatively manage that, right? So if you're a 62-year-old teacher and you have diabetes, your school district should make some accommodation for you so you don't have to teach in person.
Agree.
Absolutely.
Do you think we should be paying teachers more too in general?
Yeah,
as an economist,
I think. I think there's some debate in economics about how much extra pay correlates to outcomes. But as a whole, I honor my teachers. I think they did incredibly valuable things for me.
Me too,
and also for the kids. So I'm not against that. I mean, I'm fine with that.
Yeah.
But I think we should use the resources. Different school districts use the resources they have to creatively manage it so that kids can actually come in person.
Yeah. In
some places, maybe you can't social distance. You need more masks. In places where you can social distance, you can figure out. I mean, you have to creatively manage that. Young teachers who face very little risk, let them come in. The older teachers who are at risk, they can help the younger teachers by helping them grade, create curriculum, teach online. I mean, I think there's some mix, but the absolute must is you have to have the kids in person.
Yeah. Yeah.
With each other, or else you can't actually have schooling.
Now, you know what I think is happening too, and it's related to this, is this safety creep. So in the early days of this thing, when they talked in right here in the Bay about shutting down schools, we were thinking it'll be 2-3 weeks. And then they said it's going to be till the end of the year, the school year.
Yeah.
There was absolute horror and panic on the part of parents and kids. Like, what? You're doing what? Now, when school's supposed to reopen, it doesn't. And people have just accepted it as well. All right,
the norm.
We're keeping people safe now. It's the norm. Our kids are slowly dying a little. We're destroying poor families. We're creating a cycle of poverty, violence, substance abuse. But you know what? Safety first. And
it's not safe.
It's not safe. It's the opposite of safe.
Yeah, and I think if you think about what the scientific evidence is saying, the teachers and staff pose more of a risk to each other than the kids pose to them. There's this study done by this group in Iceland. It was published in the New England Journal. It's absolutely fascinating. So what they did is they took 12% of the random sample of the Icelandic population, and they did PCR testing on every single one of them. And they identified the virus from every single one that was positive, and they sequenced the genome of every virus. Why is that important? Because the virus has these mutations that give it like a fingerprint. And they did this detailed contact tracing study because they did the genetic analysis, like let's say I have virus A with mutation A, and you have virus A and B.
Yeah.
With mutation A and B. Well, it's possible that I passed it to you because you added on mutation B. But it's unlikely you passed it to me.
Right.
And if I have just mutation A and you have just mutation B, then we didn't pass it to each other.
Right. Separate sources. Yeah.
Okay. What they found was that there was not one single case of a child passing it to an adult.
Not one case.
Many cases of parents passing it to their kids.
Yeah.
But not one the other way.
So why are we ignoring this data?
I don't know.
And now this. So here's the counter that the mainstream media will say, well, look at what's happening at Notre Dame or wherever. There's thousands of cases, and oh my God.
Not one hospitalization, by the way.
Not a single one.
Yeah, talking about college kids, right?
Yeah.
So there's not one hospitalization.
Now, but what about these as just these horrible vectors of disease for the elderly?
I mean, asymptomatic spread happens. That's what the evidence says, but it's much less common than symptomatic spread. So the disease is spread mostly by droplets. You can have these aerosolization events, it seems like, but they're relatively rare compared to the droplet spread.
Right.
Asymptomatic spread happens, but it's much more rare.
Right.
The is unlikely. So just to give you some sense, Sweden kept its schools open, 15 and under, including daycare, all the way through the epidemic, even when cases were rising, even deaths were rising. And they did this detailed study compared to Finland. The opening and closing the schools does not have any appreciable effect on the spread of the epidemic.
What the hell are we doing?
I don't know. I think the evidence on this is so strong. It's not. And you read it and you just weep because you're saying, okay, we're making a scientifically uninformed decision.
You know what it is? It is also coming to this thing of what I call empathy versus compassion. So empathy is feeling another person's pain as your own and acting from that feeling. They ask us to do this in medicine all the time. More empathy. But what they don't realize is empathy is a poison when it comes to things like this, because here's what happens. I read an article in some mainstream media piece about a 28-year-old teacher who died of COVID after school was open. And you go, oh my God, a young teacher died. We should never have opened the school. I feel for her and her family, and she's young, and we should just stop everything. Whereas when you look at the case, okay, what were the comorbidities? They were there. What's going on? And that's one person. Did she get it from school? We don't know. Could have gotten it somewhere else. But we're going to now fail to do what we ought to have done, which is compassion, which is cognitive empathy. Understand the suffering. Look at the bigger picture. What's the most wise thing we can do for the most people to relieve the suffering, and detach a little bit? Well, if you do that, you go, well, actually, that's true, but we could have provided masks to the teachers and given schools an opening so that these children who are dying of diseases of despair or are going to get a chance, but we don't do that.
I mean, you're arguing for. I mean, that's a really nice way to put it. You're arguing for empathy for everybody, not just for a few, like the select few.
And the trick about empathy is it doesn't work on everybody. So Paul Bloom has written about this. Psychologist. It is a narrow spotlight, not just on individual, but on tribe. So empathy evolved as an in-group way. So for your kids, empathy is absolutely appropriate. My God, you better feel their pain because they are you. But for a population, you don't empathize with them. That's that's why, and the charities have known this for years. They don't show you a population of starving people. They show your help can help this child, Sally in sub-Saharan Africa. Look at her, and then you go, absolutely, because that's how we're wired.
Oh, that's
yeah, it's really interesting.
No, I think that's really right. But I think compassion, in the sense you mean it, is exactly the right thing here, right? So we have to understand. So, like the scientific evidence says that the teachers face about as much risk as other professions doing their work. Not from the kids, again, from other staff members. So, but you act on that. You say, okay, well, given that that's the case, let's structure the workplace to reduce that risk as much as we can. What they're doing is a vital function for the kids, for society at large.
Yeah.
They are absolutely essential.
Yeah.
So they're taking a risk. We should honor them for taking that risk, just like we honor the doctors that have come in or the nurses that have come in to care for their patients. Right? They're not doing something that's less vital than that.
Yeah, it's funny because you'll see memes where it was like, teachers will say, we didn't sign up for this. And the nurses will say, neither did we. We didn't sign up to put ourselves at risk, but we do our essential job. A nurse wrote an op-ed, and it's not a real contest between who's the bigger martyr. It's the idea is like they're both honored as absolutely essential. And it's tough because you do feel for people too who are at risk, and that's why it's nuanced. And something you even opened the show with, where you said you're heartbroken about the suicide statistics. That's because what you're showing is love in the face of suffering. Love and concern in the face of suffering will lead you to feel that way, right? Because you go, I can't, this is terrible. So let's have the discourse from a place of compassion. And the way that you've been treated, I think, is just abhorrent. Because that's not a compassionate response. It's let's talk. If we disagree, that's fine, and then we can have the argument. But why are we vilifying people?
Yeah, I think I don't have much to complain. I actually have been fortunate in many ways. So and actually, it's been interesting from a professional point of view to be able to contribute at all to this. It's in many ways gratifying that I've had something to say. But I think I completely agree with the spirit of it. Let's look at the data. Let's make decisions that understand that we're making decisions that affect the lives of everybody, not just the people with COVID. COVID is not the only public health danger that we face, and that there are trade-offs. There are risks on all sides. There's not a safe option where we can say. And so, I think cheap rhetorical tricks like, "Oh, you only care about the economy. You don't care about lives." I think for the most part it's aimed at shutting down this conversation as opposed to having serious conversation.
Yeah, I agree. Man, was there anything else you wanted to talk about?
I think we covered it. Thank you.
Oh my gosh, this was such an enjoyable conversation for me because it allows an airing of this kind of side of the conversation that I just don't think we're getting in a clear-eyed way. So if mainstream media does it, it's politicized by Fox. If the left does it, it's politicized by the media. I'm trying to create a space here, and hopefully we can have more conversations where we just get out some interesting information in a clear way.
Well, I'm really honored to be able to talk with you. And actually, it's been really interesting to be able to have this conversation open. I think there's stuff we probably disagree on a little. I don't know about Tom, sure. But I think having a space where you can actually do that, I think all of science should be like that.
I 100% agree. So we're going to try increasingly to use this space for that kind of good. Guys, this was a conversation. You can disagree. I want you to leave comments. I want you to leave ad hominem attacks out of it if you can. Let's try to use our critical thinking. Do me a favor, just share this thing. It'll be on a podcast. It'll be on my website, ZDoggMD.com. It'll be on YouTube. It'll be on Facebook. Ultimately, what we do is we make a little square out of it and caption it and put it on Facebook too, so you can read along. The transcript will be out in a couple days. I love you guys. Please stay well. Please let's stop stifling discussion and having it. Dr. Bhattacharya, what a real thrill. Please come back.
I'd love to.
Awesome. And we out. Peace.